Timer. Good morning, everyone. It's really an honor to be here. So thank you to ACSM for inviting me for this talk. And so we're going to talk about something that I talk about a lot, which is cardiopulmonary exercise testing. A lot of my work is, as I know some of the people in this room know me, a lot of my work is centered around this, and one of the things I'm really interested in these days is creating a more clinically applicable environment to CPX and helping clinicians to use this information in a more meaningful way, because I do think that the information is extremely valuable, and we're evolving to a point where I think we're recognizing that value in the clinical setting more so. So hopefully this will be talk will be thought stimulating and of value. So just as a couple of background slides, everyone, I think probably everyone in the room knows this classic image of the gears reflecting the pulmonary, circulatory, and skeletal muscle systems, and the transfer of oxygen from the environment to the mitochondria and carbon dioxide back out. And this is, one of the initial slides demonstrating elegantly, I think, the true value of CPX, that using expired gas analysis with other measures can give you a good representation of how these three systems work and start to gauge what is actually limiting exercise, because there could be a number of mechanisms if such a limitation exists. I'd like to plant a seed and go a little bit further. We just published a review paper, John Myers, myself, Marco Guazzi, and I think, and hopefully by the end of this talk you'll agree, that we can actually tease out some more of the physiology beyond just cardiac, pulmonary, and skeletal muscle, and in particular, one of the true values, I think, of CPX, and there are a number, is looking at the pulmonary vasculature and the right side of the cardiac system, the right ventricle, and what's going on there. As we go through the different clinical indications for CPX, I really think there is an underappreciated value of what CPX could give you with respect to that. But there is a growing recognition, and now we need to translate it over more towards clinical practice. And again, just to create a background of information with respect to CPX and where I think some of the underappreciated but increasingly recognized value is looking at ventilation perfusion matching in the pulmonary system and looking at ventilatory efficiency. So those of you who know my work, a lot of it has been focused on how we use ventilatory inefficiency to predict outcome, to diagnose exercise limitations, to gauge disease severity, and this is really an area where we could translate it over more towards the clinic. I think the data is there. Now we need to start to get more towards clinical applicability, more so. So I did a quick and dirty search of cardiopulmonary exercise testing. So just put in cardiopulmonary exercise testing just to look what's out there. So it's not a perfect system, but just to demonstrate that there is a wealthy body of evidence. And so the premise of this talk is aligning the evidence with clinical practice. And I put this here to make the point that there is, last time I searched, well over 3,000, coming up on 4,000 publications with this search. There is a wealthy body of evidence there to draw from. So now that the issue is, or the challenge that we must embrace is, how do we take that body of evidence, put it together, and help the clinician to use that for meaningful clinical practice. And if you look at how the body of literature has grown, it reflects the emergence of the technology, the improvement of the technology, the reduction in cost of a CPX unit, but it continues to grow, the number of publications. So I like this area because there is a lot of data out there to draw from and pool together and make some good recommendations. So why have we limited our applicability? What's the issue with clinical practice when we think about the value of CPX and why we're not using it to its full capacity in the clinical setting? And I mean no disrespect to the 9-panel plot at all. As a physiologist, I really like the 9-panel plot and looking at it and understanding the physiologic value and interpretation of it. But think about the clinician, think about the cardiologist who has a CPX lab and wants to gauge some information that is relevant to a patient's prognosis, how they can guide therapeutic strategies moving forward based on this information, how to gauge disease severity. And I do think, it is my opinion, that this approach, which is somewhat perpetuated by the metabolic systems and the software applications, has limited clinical interpretation and clinical application to its fullest capacity. And I've had countless individuals over time who aren't experts in CPX come to me with a 30-page printout report and say, I just did this test in my patient. What do I do with this? What do I do? What does this mean as far as the patient's outcome? What do I do? And so I think that's, that's where there's a body of evidence, and then there is, what do we do with that body of evidence? And that's where I think we need to go. And because of that, I think over time we've run to a recognizable value, right? I think still, if you look in clinical practice, and I used to be on a heart transplant team, I used to do the CPXs. I started to do my doctoral work and very much into ventilatory efficiency, and I kind of was, I think, ahead of where the literature was to a degree, because I would want to talk about ventilatory efficiency with the transplant surgeons, and I said, they go around the table and we talk about appropriateness for transplant candidacy, and they'd get to me and they go, was there peak VO2 above or below 14? I said, below, but. And they go, no. I said, well, I have more. No, that's all we need to know. Next. And, oh, please, let me talk a little bit more. And I think we've still kind of been stuck with peak VO2, because that is one thing that's recognizable, aerobic capacity. It's something that everyone can identify with. And so we're somewhat still stuck there with what's their peak VO2. And really we need to transfer over to this three-dimensional view that, there's peak VO2, and it's certainly a key metric, but there's also value in carbon dioxide production, in ventilation, in looking at that link. And then the other variables that aren't related to expired gas analysis that we all know, hemodynamics, ECG, subjective scales, that we almost have lost an appreciation of when we do a CPX. So when we do a traditional stress test, it's my sense that we pay attention to those things. But then when we put a mouthpiece in, it's like, well, now we don't have to worry about hemodynamics and ECG and what that means prognostically or clinically. And so we need to kind of bring that back into the three-dimensional picture as well, because all of these variables give you that three-dimensional snapshot of what someone's pathophysiology looks like. And that gives you the better information with respect to prognosis, how you gauge therapeutic applications, disease severity, and those types of things. So that's kind of the background. I'll try to leave some time for questions at the end. I'm usually pretty good with timing, so we'll see how this goes. Okay, so show of hands. I think I could see you out there. How many people are familiar with this publication? Okay, so there's some that aren't, and so that's good. So I'm going to guide you through kind of how our group has tried to package differently CPX data into something that is more clinically applicable. And I'm gaining a greater appreciation of data visualization going to Chicago. We have a department of health informatics, health information systems, and biomedical visualization. So, when you think of, and people say, well, what's that department? I really love that department and align with them very strongly in a number of ways. But when you think about biomedical visualization, everyone kind of runs home to, well, they do medical illustrations, they do the Netter book, and yes, they do. But they also have a very keen interest and a lot of focus on how you take data and visualize it to be used in the clinical setting. And so it's kind of the karma of the world, right? That that I did this publication with a really great group of colleagues from both the US and Europe before I came to Chicago, and then the stars kind of aligned and I did a talk there, and the BVIS group was there and talking about this is what we do. We take data and we visualize it and present it clinically, or how it can be used clinically. So, you know, it was kind of, I was, I guess, a little bit ahead of my time, but now things are really starting to come together and think about how we use this data moving ahead. But I just want to walk you through how, you know, we think about CPX with this publication, and then as we do updates to it, and what our thinking was with respect to this publication. So when you talk about the three-dimensional view, these are the essentials, and the evidence kind of drives this. And this publication was all evidence-based. You know, what are the variables that seem to predict outcome in combination, or in combination help guide diagnosis or gauge disease severity. There are some variables that some of you will appreciate and recognize that have some publications that we didn't put in the initial guideline statement because there wasn't enough clear evidence to indicate they should be in the three-dimensional view. That's not to say that they won't be in the future, but we really tried to stick with where the evidence was taking us. And even with that, there are some holes that I'll discuss at the end of where we need to go next with CPX. But certainly aerobic performance, peak VO2, VO2 max, however you want to define it, ventilatory efficiency. I'll talk about pulmonary function. I think that's something else we don't appreciate as much with CPX. Most units will allow you to do pulmonary function testing, and we're starting to appreciate the pulmonary system, and not only FEV1 and forced expiratory volume, but inspiratory muscle strength, and how we start to capture that, and I'll kind of tie that in the end with future directions. Hemodynamics, ECG, and subjective scales. This is where that volume of data of about 4,000 publications has taken us. It's these essentials. And now how do we package it in a patient-specific way? So taking it based on each test indication and packaging it just a little bit differently that's unique to that patient population, and that's kind of what we tried to do. And we tried to condense it down into something that is 2 pages and very visually appealing and recognizable. So what we did was we created a universal CPX reporting form with all of the variables that you would want someone to capture from a CPX. So peak VO2, ventilatory efficiency, hemodynamics, so on and so forth. So we boiled this down to 1 page, and we advocated for, if you have your technician doing the test, fill out this page, fill out the test indication, and then let this universal reporting form be the template or the guide for the specific algorithms I'll share next with you. And then we boiled it down to 2 graphs that the evidence would indicate should be included in the reporting forms or require some interpretation, and not for every patient population, and we'll kind of go through which ones. But looking at the relationship between oxygen consumption and the oxygen pulse and workload or exercise time, because of that flattening or drop in the curve with the progressive exercise test, does seem to give some unique insight into acute changes in LV function. So thinking about suspected myocardial ischemia, there seems to be some applications here, although there needs to be more research in this area. But it is a compelling application of CPX to think about. And then I think probably most people in the room are familiar with oscillatory ventilation during exercise. In heart failure, we're also starting to recognize it in pulmonary hypertension populations. I was just part of a group that recognized that certain individuals that are so-called apparently healthy oscillate as well. But individuals who have this oscillatory pattern, this is a pathophysiologic phenomenon. This is not noise or error when it occurs. And I'll talk about where we need to go with EOV and how we quantify it, because right now it's more of a visual type of thing. We need to put it or boil it down into a number, take it and somehow package it as an electrical current or some type of frequency in hertz and make it clinically applicable, and I'll touch upon that. But right now the evidence is indicating those two graphical depictions are part of that universal reporting form and should be assessed. All right, so let's walk through the different algorithms out there, the different patient indications. So this is the one for heart failure, and this is where the evidence has taken us, and it still holds true even though this was a 2012 publication, but this is still where the evidence takes us. VEV-CO2 slope, and a lot of my work has been done in this area on a 4-level classification system of less than 30 to greater than 45, and we color-coded it. And obviously green, good prognosis, good outcome. And as you progress, your prognosis and your outcome becomes worse, to the point where if someone has a slope greater than 45, that really doesn't portend a good prognosis for that individual in the short term. Peak VO2, same 4-level classification system. The evidence indicates using the Weber classification, which has been out there for quite some time, still holds true. There's no reason to think about a new threshold value, and in fact that 14 value really doesn't allow you the optimal resolution, that it's more of a progressive worsening of prognosis as you go from, say, above 20 mLs per kg per minute to less than 10. So the evidence would point towards more of a multi-level system than a single-tiered system. Do they oscillate or not? Green if they don't, red if they do. Looking at end-tidal CO2 both at rest and how it increases during exercise to a maximal level, the evidence would indicate right now that more of a threshold value of 33 at rest or greater, and then somewhere around 3 to 8 millimeters of mercury increase during exercise is a favorable response. And we looked at the studies out there looking at the multivariate regression analyses, because this is more prognostic, to guide us. So these variables most often stuck together. They came out in these multivariate models, which is why we put them all in the algorithm together. So that's the expired gas analysis panel. 4 variables for heart failure. And then let's not forget hemodynamics. Does their systolic blood pressure rise somewhat? Is it flat or does it drop? There's evidence to indicate that's prognostic and important. Why did you stop exercise with respect to ECG? Were there any changes that would warrant test termination prematurely? Were there arrhythmias but you didn't stop the test, or were there no arrhythmias at all? Heart rate recovery. And there's a wealth of data out there showing that heart rate recovery is valuable, and so the evidence would dictate we think about that as well. And then lastly, the subjective scale. Subjective reporting is important, that if a person reports they terminated exercise because of leg fatigue versus dyspnea, that the evidence would indicate there's a difference in prognostic resolution here. Now notice we didn't weight these things, and we'll talk about that at the end with respect to the future. That we color-coded it, but we didn't provide a weighting system, and that really I think needs to be done, and we'll touch upon that. So this is the visualization of it. This is, hopefully this will, or has, because the paper's been out for a bit, improves clinical interpretation. And I encourage the metabolic cart companies, of which I have no relationships with any, but I would love if all of them threw this up into their software reporting forms and auto-populated and printed out a 2-page sheet versus a 30. I think this would really help the clinician. But so say you had a heart failure patient that looked like this, you can visualize what their prognosis would look like or their disease severity versus someone who looked like this. And the red flag should start to go, the alarm should start to go off, and the red flag should start to go up with, I need to think about what we need to do with this patient in the short term, because I know CPX is very prognostic, and this is telling me that this person's in trouble, probably a transplant candidate or a device candidate. So this is kind of where we're going with this type of thing. Okay, so moving on from heart failure, and that's, CPX is not it's an elegant technology, but it does not have to be complicated. The physiology behind it and clinically applying it does not have to be a complicated thing. And so these algorithms are rather simple and evidence-driven, and again, we hope that it improves clinical practice in this way. So what about unexplained dyspnea? You still want to look at ventilatory efficiency because of, do they have unexplained dyspnea because of ventilation perfusion mismatching, because of exercise-induced pulmonary hypertension. You want to report their VO2 in a % predicted value because there's a much wider range. Some patients go well beyond the Weber class, maybe a normal VO2. There are limitations with any regression equation for predicting VO2 that's out there. We proposed the Wasserman equation because it used the most predictor variables at baseline and considered body weight and so on. But we recognize that there's no one perfect regression equation out there right now. Pulmonary function testing pre and post is important in this population to rule out exercise-induced bronchospasm, and most systems can do it, or you should really have one in your lab to do pre-post testing if you're going to test for unexplained dyspnea. Then hemodynamics, ECG, and pulse oximetry to further refine, is it the heart, is it the lungs, is it something else that's limiting their exercise capacity. And heart failure and unexplained dyspnea are the two most common indications and referrals for CPX. And so we do a lot of patients that have unexplained dyspnea, but are we doing a good enough job with these patients come for this test? And then where does it shoot them off towards? Does it improve their outcome? Does it improve their care? Does it appropriately diagnose them or help to appropriately diagnose them? And there's not really a lot of literature in that area. We don't know, and I'll talk about how we need to kind of touch upon that better in the future. So this is just an example of the classic exercise-induced bronchospasm response. Someone who was young, was a runner but would get winded and have to stop exercise. They bronchoconstricted. Symptoms in this individual for 3 years. Multiple different types of tests because CPX is sometimes more of a back-end assessment versus a front-end with unexplained dyspnea, and I'll talk about maybe retweaking that algorithm. But had this response, gave this person a bronchodilator, and it normalized. I like when someone has exercise-induced bronchospasm with respect to unexplained dyspnea because it's easier potentially to fix. And this is how the color code would look. They'd have normal ventilatory efficiency, their peak VO2 or their aerobic capacity may be limited to some degree. They're encroaching upon more of their maximal voluntary ventilation. They have abnormal pulmonary function response, but their hemodynamics look normal and their pulse oximetry looks normal. So again, visualizing the data. I'm really becoming a big believer now in Chicago with that department of how we visualize this data, and I think CPX is ripe for this. And then another example is someone with exercise-induced pulmonary hypertension. And so there is a body of literature showing that ventilatory perfusion matching, if it is off, if they have pulmonary hypertension, these values hold true. VEV-CO2, PET-CO2, they become abnormal, and there's a number of studies demonstrating that these variables are important in teasing it out. So I'd ask the CPX labs that do unexplained dyspnea, do we pay attention to ventilatory efficiency enough? Do we assess it, and do we use it in our reporting schemes when we're trying to determine what the limitations are for these patients? And this is how an example of someone with exercise-induced pulmonary hypertension may look. Their ventilatory efficiency is off. Their aerobic capacity may be much worse because of the pathophysiology. Their hemodynamics may be abnormal because of the encroaching or the shutting off of the valve, if you will, with pulmonary circulation going over to the left side. And these are just examples. These aren't real patients. I'm Italian, so I'm very fatalistic. I think I lean that way. It's like, well, how can I make this look? Let me just make it look horrible because that's what Italians do, right? They make everything look horrible. ECG response, they may trigger right ventricular or right-sided heart arrhythmias. A lot of patients with pulmonary hypertension that we get, actually have these arrhythmia triggers, and their pulse oximetry may be off. So patients with sarcoidosis scleroderma that have, are you trying to figure out if they have some pulmonary limitations? We were starting to get a lot of patients referred as they came more towards the end of their disease process and got exercise-induced dyspnea. Moving towards the future, we didn't include this in the algorithms, but I think this is important to mention. Certain CPX units can now capture flow volume loops during exercise. I love this application. And I think this, moving ahead as we rethink the algorithms, should be included, because you do a maximal maneuver at rest, and then you capture the flow volume loops during exercise, and they shouldn't encroach. Everyone knows in the room there should be this pulmonary reserve that you don't really encroach upon with normal physiology. And then you can capture individuals who are starting to encroach upon and overlap with their maximal flow volume loops at the end, or are they having to push really hard to get that air out? So this, I think, will further add to the three-dimensionality of an unexplained dyspnea assessment. So then moving ahead, and I'll move a little bit quicker through these, because the themes kind of continue to ring true, and just to kind of highlight the patient populations we looked at, because I really want to get to the end and leave time to talk about the future, and I want to leave a little time for questions. But there's a growing body of literature for pulmonary hypertension, and this is kind of that. Heart failure is very big with CPX, and I think for pulmonary hypertension it should be the same thing, either suspected or confirmed. We're starting to get a body of literature that's showing it is very prognostic, the same variables, peak VO2, ventilatory efficiency, and so on. The literature is not where it is with heart failure. It's not as big, but we're getting there. And I think we're coming to a point where pulmonary hypertension patients, as we're assessing them and determining what to do with them clinically, CPX should be part of the standard assessment for these patients. But this algorithm looks a lot like heart failure. Their ventilatory efficiency, VEV-CO2, Untitled CO2, because of gauging their ventilatory perfusion coupling. As their pulmonary hypertension gets worse, this mismatch gets worse. Greater disease severity, worsening prognosis. The Weber class holds true in this population. Most patients with pulmonary hypertension, they don't really go very far above a peak VO2 of 20 with their disease, and they certainly can drop below 10. And then hemodynamics is important. As that flow gets cut off to the left, there's a blood pressure drop with exercise, which is ominous. Do they have ECG triggers, mostly from the right side of the heart, because that right side is getting taxed with that increase in pressure? Also ominous. And then their pulse oximetry. Do they desaturate, which isn't a good sign if they do with physical exertion, especially at lower exercise capacities. Not a lot of literature in heart rate recovery. You'd suspect that heart rate recovery could be valuable, but we let the evidence guide us with these algorithms. So just to kind of, I guess this is shameless promotion, right? I could have picked any paper, but I picked one of our papers because that's who I am. Everyone in the room who knows me, I am a shameless self-promoter, so that's what I've done here. I love to talk about myself. I'm kidding. It's recorded though, so maybe record the I'm kidding part too. But we looked at, this is in a heart failure population did I ruin this? I ruined this thing. Okay, so the laser pointer's gone. All right, so I'll move on. But we used Doppler echo, and we used a threshold of pulmonary artery systolic pressure of 40. Granted limitations, and these are resting values, and then looked at does VEV-CO2 slope help to tease out patients above and below that threshold. Almost everybody with a VEV-CO2 slope greater than 45 had surpassed that threshold. Everybody with a VEV-CO2 slope less than 30, just about, we're below it. So heart failure, what we're starting to gain an appreciation of is the implications of secondary pH in patients with heart failure, and the implications for that, and the potential treatment approaches for that. So I think there's a wonderful opportunity, an added opportunity with CPX and heart failure with respect to this. So now you have a heart failure patient. We're starting to recognize they have a VEV-CO2 slope of 48. Their prognosis is really bad. And so, okay, what do we do next? And we quite haven't integrated how we use CPX for that. But it's likely as well, and there's other studies that show this, that say they have secondary pH. You're pretty sure they do. And so now how do we take that information and better manage them clinically? How do we use that CPX data to better manage them? So this is an example of secondary pH. And then with EOV as well in this paper, combined with VEV-CO2 slope, was even a better predictor of who had a pulmonary artery systolic pressure above 40 versus below. Hypertrophic cardiomyopathy, also looking at ventilatory efficiency because of secondary pH. We recommended the percent predicted VO2 because you can have certain patients with HCM who have a normal peak VO2 versus a very compromised one. And then paying attention to hemodynamics and ECG are important as well. There's not as big of a body of literature in this area, but enough to make some recommendations, and we did. And we were always very cautious about branching off too far. So this was another shameless plug, but this was one of the coolest studies I've done. So at NIH, there's this whole intramural side, and I was an intramural investigator for my CPX background. So they had a hypertrophic cardiomyopathy cohort in a cath lab with a stress echo system set up to do Doppler echoes, and then they had me come in and drop in the mouthpiece in the cath lab to do CPX while they were right heart cath, while they were getting echo, all at the same time. That was just so cool, and I really enjoyed that experience. But what we found was same theme. Again, this is not some magical system with all of these different variables, and we have to look at it different ways. Ventilatory efficiency holds true in a hypertrophic cardiomyopathy population as well. If their ventilatory efficiency is off, they likely have secondary pH, and we need to pay attention to that. So what about COPD and interstitial lung disease? We don't do as much CPX in these patient populations, but same themes, ventilatory efficiency, and I'll explain why. Weber class still holds true in these patients, and then hemodynamics, ECG, there's a body of literature with heart rate recovery with the same threshold values, and then pulse oximetry as well. And so what we're finding with CPX, why maybe we would want to do this, well, for multiple reasons versus the 6-minute walk test, is because if you have these phenotypes in COPD and interstitial lung disease, that if their VE/VCO2 slope is high and their end-tidal CO2 is low, it is much more likely they have pulmonary hypertension. So identifying that phenotype because of the implications of pulmonary hypertension and trying, if you can, to do something about it and being able to identify it is very important. And CPX can help to do that in these patient populations. So this is one study in COPD. This is another example in individuals with interstitial lung disease. Same thing, significant differences in end-tidal CO2 and VE/VCO2. Both studies, however, showed that their peak VO2 was comparable. No pH versus pH. So not that these studies looked at 6-minute walk, but if peak VO2 is comparable, 6-minute walk distance you could hypothesize would also be comparable. So looking at ventilatory efficiency in this population is important as well. So this is, an example of someone with COPD without secondary pH that looks pretty good. This is the Italian model, someone with secondary pH who looks really bad, who has secondary or pulmonary hypertension and so on. So okay, here's a controversial area, and so you think about the intersection of evidence and economics, and I think healthcare is going to change completely with the way we think about services and what we pay for, and some different models of financial responsibility. But right now, you have chest pain, you go to you get a nuclear stress test. Well, my lab was in, VCU was in non-invasive cardiology, and we did nuclear stresses in a lot of patients. There's a good growing body of literature to say if you look at those curves and you do the test the right way, so look at their oxygen curve, if it flattens or drops, or oxygen pulse flattens or drops, it is pretty sensitive and specific for myocardial ischemia, and it looks pretty comparable to the sensitivity and specificity for a nuclear stress test. Cost of a nuclear stress test, cost of a CPX. Interesting. And then think about walking into a clinic saying, yeah, we're not going to do those anymore. We're going to do these. And that's an interesting journey, but we're keeping track of this body of literature. It was an Italian study that came out first of about 200 subjects, but there's been some others that say those curves can be rather telling. And then you start to think about the limitations in nuclear stress testing, men versus women, micro versus macrovascular disease, and we're starting to appreciate the fact that maybe men get a nuclear stress test. Maybe they go in this direction. But women, we need to send them somewhere else. Is it stress echo to pick up LV dysfunction, or is it CPX? You know, can CPX, because CPX doesn't really care with respect to micro versus macrovascular, it cares about LV dysfunction. So if your LV dysfunction kicks up, your curves are going to drop. So thinking about the sex-specific differences and the opportunities for CPX here. So this is an example of a normal response with the normal VO2 progression during exercise and a normal O2 pulse versus someone who flattens out and had myocardial ischemia. And so we put an algorithm in there, but again, more research needs to be done in this area as we move forward. And then we put this one in. This is more of an interesting emerging area, but thinking about mitochondrial myopathies. This is the last one we put in there. So there's this technology now, this add-on that most CPX labs don't have, that can measure cardiac output with an inert gas, with a rebreathing technique. And the technology's improved. The earlier technology would say, okay, if we're going to measure cardiac output during exercise, and I've seen these before, these are interesting. You're going to be exercising really hard, and now we're going to measure cardiac output. Now, take a full breath while you're exercising. Keep going, but take a full breath. Have you ever seen anyone try to do that? Even a fit person? That's fun. That's a lot of fun for them. It's really difficult to do. But now the technology has changed to the point where you don't need to do those maximal maneuvers. So there could be a growing opportunity for quantifying cardiac output in a different way. But there is some literature out there saying that, you know, if you have, so you have a normal cardiac output response, but you're not consuming the oxygen in the periphery, those slopes go haywire to a degree. So is there an opportunity for CPX as a first-line assessment to start to look at mitochondrial myopathies? And so there's a body of literature there, and we felt it was enough to put an algorithm in place. And so this was one of the earlier studies showing that, you know, individuals with a mitochondrial myopathy confirmed diagnosis had a much higher change in cardiac output to change in VO2. Everyone who was normal looked pretty tight. Okay, so where do we go from here? There's a big body of literature, but it still doesn't tell the whole story. We still have more work to do. So just as a snapshot of some things I think we need to look at. So you'll notice in the algorithms are color-coded. They provide a nice visualization of a good outcome or a good test versus a troubling test. But there's not enough literature out there to weight the different variables. You know, we've done some of that work. Slope, VE/VCO2 slope, seems to be a stronger predictor than peak VO2, for example. So you'd maybe want to weight that heavier than peak VO2. Not all studies show that, but a majority of the studies do show that. Where does heart rate recovery fit in? Oxygen uptake efficiency slope is still kind of on the radar. So I think thinking about pooling our CPX databases so that they're robust enough to come with a weighting system, combining that with the color code is going to further refine the algorithm, because not all of these variables, although they may be important and may stick in the multivariate model, aren't all weighted the same. So there is that gap right now between what we know about in the literature and how we clinically apply it. So I think we need to direct some efforts towards this. Quantifying oscillatory ventilation. So right now it's a visual, it's kind of, there's a Cora technique, you know, if they oscillate more than 60% of the test at an amplitude of greater than 15% at rest. God, I've got to get a life if I could know that by heart. That's troubling. All right, so, but we don't, can we mathematically quantify this and come up with some thresholds of if they oscillate and it's this amplitude and this frequency, is that bad versus, you know, this is okay? Because this is going to, oscillatory ventilation, which is a real phenomenon and interests a lot of us, is going to suffer as long as we don't have a way to give it to the clinicians and say, this is what it means. And so I know there's some studies coming out doing that, bringing in you know, engineers and people that are very good at math and saying, here, take this and quantify this. Look at it like an electrical current or some other way and give me a number that I can test and say with an ROC curve or you know, a Cox regression and say, okay, this predicts outcome. And I think we need to start to focus on that because EOV is very important in heart failure and looks like pulmonary hypertension too. And then let me spend a few minutes on this. Translating science to practice. So where CPX lives right now, we got a lot of really good, most of those studies I cited initially, the ones in there, at patient-centered research. We've got these big databases. We said CPX is prognostic. We know that in heart failure. It's really good at diagnosing unexplained dyspnea. It helps a lot. There's other applications. The evidence indicates that clearly. But then what we don't know, what we haven't really studied is, okay, you apply it in the clinic, how does CPX improve outcome? How does it save on cost of care because you filtered a patient this way versus that? We don't know that. We don't do enough of that research, so we need to start to think about it in that way to further bolster how we use CPX and how we think about it. And until we do that, I think it's going to suffer with respect to, you know, having its true place. I do believe that if you think about CPX in a certain way and administer it in a certain way, it does. It's a cost-efficient assessment technique of function. But we need to start thinking about taking that information back and tweaking it, doing more research, and refining the delivery model. And so I still, you know, I put this up here. Mike Lauer in 2005, who I know well and respect immensely, he did an asymptomatic population exercise testing statement in 2005. This was a while ago. And said there's enough evidence out there to say we may want to just start exercise testing everybody in the apparently healthy population because it's very valuable information. But what we don't know is we need to start doing research to say, okay, we're going to apply this. How does it improve outcome? How does it save healthcare dollars? How does it change the clinical trajectory? And we haven't done those studies yet in an apparently healthy population. The reason why I put it in this study is to say we already have the infrastructure in place with CPX in disease populations. We can easily start to do this research. We just need to start doing it. And so I put this slide up here to make that point. So here's some examples of how I think we should start looking at this. So the timing of CPX in heart failure. We typically, or we tend to do it kind of at the end, right? They're progressing along. Okay, things are not looking good now. Let's order a CPX and see if they need a transplant. Well, what about, and okay, that's fine and good. What about if we started doing it early, when they have LV dysfunction, or you know they start manifesting the first signs, and can we use that CPX data to bring them back a bit or keep them managed better, titrate their medications? Do we identify ventilatory inefficiency earlier and start to manage their pulmonary pressures better? This is an example of, can CPX alter the trajectory of a patient, improve outcome, and save healthcare dollars? Because what you really want to prevent for as long as possible is them getting to the end, of them getting to the highest level of disease severity, which is going to cost us the most money. So that's one example. Here's another one. Unexplained dyspnea. Most of the time you come in, I have shortness of breath. All right, well, you're going to get a normal stress test. That's negative. Okay, go home. You're going to get an echo. You're still having unexplained dyspnea. That's negative. And then there's a span of time that goes by. So you still have unexplained dyspnea. Well, you know, something's going on. And then they make their way to the CPX after multiple assessments, after years of symptoms and poor quality of life sometimes. What about if we did it, you know, they come into the lab, they have unexplained dyspnea, and we did this, CPX right away. And then how does that change the clinical trajectory? And does that save money? There's a theory, there's a hypothesis to say it would, but we need to start doing that research as well. And then this was a paper I had the honor of working on and publishing with my group not too long ago. Rating the evidence, I think, is an important piece that will further refine. We didn't rate the evidence in the 2012 paper. And if I'm a big AHA guy, I like AHA a lot. I like their level of evidence and classification system. And I looked at it a couple months ago and said, wow, your language is directed towards interventional trials. When you look at everyone's familiar with this, the level of evidence and class system, but it's all directed towards intervention and randomized controlled trials. The language does not fit rating evidence for CPX. So we did just that in the ESSR publication that we published not too long ago, where we changed the language to make it prognostic, diagnostic language and rated the evidence and classification system that way. It's an incredibly busy slide, but it's colorful, right? I don't expect you to read it. But I encourage you to go look at the paper. And then I encourage groups. We did this as a template for heart failure. I think we need to do one for pulmonary hypertension. We need to do one for unexplained dyspnea, and the other myocardial ischemia, and so on. There's a wealth of papers that could be published in this area. But we changed the language of class 1, class 2A, class 2B, and so on. And then we provided in that paper level of evidence recommendations for, what variables are class 1, level of evidence A indications for heart failure, and so on. And so I encourage you to go look at that paper. And we kind of took the AHA playbook and made a recommendation table and changed the language a bit. So I hope you kind of enjoy that paper. So all right, some closing thoughts. Exercise testing is safe, right? Do we need to go over this again? We don't, right? That exercise testing, even in very high-risk populations, is extremely safe because people who are well-trained do the tests, and if something bad's coming, they stop. And so we have very few events, so we're good, right? We know. We should do these exercise tests even in patients that are looking to be high risk. And this is not this lecture. And we should send those patients to cardiac rehab when they're eligible, because it doesn't have to be a 50-year-old male that looks pretty good and had, PCI and lost a little bit of LV function. There's data to indicate we need to get the higher risk people in there even more so, but that's another talk. And we also know, right, that the model really of having the physician in the room isn't an effective model. I am a big believer, Paul knows this, in physician proximity. Physicians need to be there in case there's an adverse event. Embedding labs in non-invasive cardiology units, I am a firm believer in that when you test high-risk patients. But you can get non-physician health professionals, exercise physiologists, other well-trained professionals who can do these tests, work with the physician, and then that model works. Because if you're going to say the physician needs to be in the room and get away from doing their billables and seeing their patients, that model does not make economic sense. But the data says a non-physician health professional can easily do these tests proficiently and work as the team approach. And we published a paper through AHA, had John Myers, PhD, exercise physiologist, and Dan Foreman, a cardiologist, co-chair that paper. So broad support and consensus for this model. And then the future of the labs. So we do CPX right now, right? Inspiratory muscle strength and endurance. We need to start to quantify respiratory muscle strength better, because we're appreciating the fact that heart failure patients and patients with pulmonary hypertension have respiratory muscle weakness that contributes to their functional limitations. And we need to start training them or incorporating that into their exercise programs, but we need to identify it. And there's a really good body of literature there as well. And then we really don't do any assessments in a traditional CPX lab of muscle force production and endurance. So you think about your frail cachectic individuals, we need to start to gauge and direct some attention towards muscle strength and endurance and provide some guidance there as well, especially in the elderly population where perhaps an aerobically based cardiac event isn't the big concern. It's fall risk that's the big concern. So I think the future exercise or functional lab should incorporate all of these things and not be as siloed as it is right now. And then I'm almost done. I'll leave like a minute for questions so you don't yell at me. I'm very fragile. And so CPX, I'm a big believer in CPX. But CPX isn't going to be available everywhere. Maybe someday as the technology becomes more widely available and the cost goes down, but assessing function with whatever you have available is important. 6-minute walk tests, step tests, traditional exercise testing approaches, bringing an ergometer into a room and doing a functional assessment. Assessing someone when they physically exert themselves is valuable, and we should do it more. So while this was a CPX talk, I never lose sight of the fact that assessing function is a very valuable and important thing to do. All right, so I'm done. I just want to say a couple of thank yous. Is John Myers in the room? Where is he? John, okay. So wait, I just wanted to make sure. There's a whole bunch of ways you can express your research profile, web indexing, and all this. I love this graph that you can get on Web of Science. that it gives you this moving thing of all of the people that you publish with. And I'm always very humbled by the fact of the people that I've published with. And I'm really, all of them could be up here with me. I am nothing without my group. And you know, this is me over here. I couldn't get the green thing to go away. And I didn't, there's no order to this, but I do want to recognize one person who had a tremendous impact. So John, that's your dot right there. And I put you in the center on purpose because you have really impacted my career and our personal friend, and I'm very appreciative for you always. So thank you. And then my children who aren't here, who I wish were, they hold me up, and I love them just so much. And I can't be thankful enough for them on a daily basis. So that's it. And now you have 4, 3, 2, 1. Thank you, everybody.
So Ross, I do want to thank you for that excellent and entertaining overview of CPX. Are there questions? And if there are, please, we don't usually do them at presidential lectures, but we will since we have some time. So if you have a question, please go to the microphone, state your name, rank, serial number, and what you want to ask.
Bob Garofano from Columbia, New York. MVV can give you a little insight into muscle strength. And when I see pulmonary hypertension patients, I don't see their MVVs either lower than their percent predicteds or dramatically small or low. Do you find that?
We haven't, there's really not a lot of formalized analysis with MVV and pulmonary hypertension, but I agree with you, there is a rationale to look at that, and I think we should. I think heart failure, there's a reason to look at it as well. It gives you a better perspective of all the systems that are limiting, but I personally haven't as much, but I can certainly see a reason as to why. We should look at that.
Thank you for a lovely talk. James Hull, I'm a pulmonologist in London. I just want to make a comment really about peak flow, another surrogate of respiratory muscle strength more than airflow. Mm-hmm. So I'd urge people not to use it as a marker of exercise-induced bronchoconstriction. It drops when people don't take a deep breath in. And FEV1 is probably the more appropriate measure to use. Also a comment really about, do you think we may be overcomplicating our interpretation? For instance, if we order a HRCT scan to look at lung fibrosis, we expect a radiologist to make some sort of comment about that scan and say, look, this is prognostically poor, this is likely to be the differential diagnosis. And maybe actually we have to accept to a degree that CPET is the same. We're going to have some individuals who are experts in it who may be able to interpret the findings and then present that to a clinician who's referred that case.
So you're asking, I'm sorry, I don't understand what
I'm just saying that maybe actually, obviously we're trying to objectivize, characterize the numbers that we get and present that in a format, but we may have to accept the fact that actually we still need an expert to say, look, actually, this is what I think this is in unexplained breathlessness.
Yes, I do. I do think that this by no means is to remove the experts in CPX, but I do think visualization is important for broader applicability. I think every exercise testing clinical lab should have an expert in CPX. But getting everyone to kind of buy on and be able to visualize it, I think we need to present the data in a different way so that people can understand it a little bit better.
Thank you.
Thanks.
So it's 11:25. Thank you all very much. And Dr. Rena, thank you very much.
Thank you, everybody.